Hi, everybody, and welcome to the third session of this learning community for HUD, rural, and unsheltered NOFO grantees. I hope you've been with us the first couple sessions or were able to check the recordings. If you're just joining us for the first time, my name is Jen Elder. I am the director of the Homeless and Housing Resource Center and just super thrilled to be working with this phenomenal team from the Technical Assistance Collaborative, who's providing the SAMHSA TA to the grantees. So I'll start with just a couple of disclaimers and housekeepings, and then we'll turn it over to the team. We have a number of guest presenters today. So next slide. A quick disclaimer that the Homeless and Housing Resource Center is funded by the Substance Abuse and Mental Health Services Administration, but the views and opinions we express today aren't necessarily those of SAMHSA or HHS. Next slide. Perfect. We have American Sign Language interpreters with us today, so big thanks to Pamela and Dave. We also have live transcription from a human captioner, so not AI here. So we just are really appreciative of our captioner giving their time and expertise to us today. So if you have any technical difficulties, feel free to reach out to us. Next slide. Right before I hand it over, one change that we made from last session to this session is we have changed it to a Zoom meeting room instead of webinar room. So you can still use the chat. We don't have the Q&A feature, but that's okay. We're a small good group today, so we can use the chat for questions. You'll also be able to mute and unmute yourselves if you want to verbally ask a question during the session. So that just wanted to note that change from last week. So with that, I will hand it over to Rachel to get us started.
Great. Thank you so much, Jen. My name is Rachel Post. I'm a senior consultant with the Technical Assistance Collaborative, and I'm really happy to be here today in our third session where we get to feature some really prominent organizations that are exemplifying a lot of what we covered in session 2. As you may recall, for those of you who joined session 2, we really talked a lot about doing resource mapping so that we know as a homeless service provider, as a provider of supportive housing, that there's so many other systems that we need to bring together in our partnership. And that includes our community health clinics. It can include our alcohol and drug and behavioral health provider partners, our harm reduction agencies in the community, street outreach workers, employment support service systems. And so last session, we spent some time showing you all how to create your own resource map and crosswalking. We gave you some excellent links to find out who those partners are in your locale. And then today we get to actually introduce you to 3 folks. We have Dr. Rajni Shankar Brown, who is here to talk about Foundations to Freedom, which is a community-based organization in Florida. We have James Ginsberg with Recovery Works in Colorado, and then we have Daryl with Aspire Indiana. And they're all going to talk about how they have worked to bring these different systems together to partner with the services that they deliver. And then we're going to have some panel discussion. And so with that, I would love to introduce Dr. Rajni Shankar Brown, and she is among the most prominent educational scholars in social justice in the United States and internationally. She's an associate professor, endowed chair of social justice education, and a recipient of the Hand Award for Distinguished Faculty Achievement at Stetson University. Dr. Rajni also serves as a member of the board for the National Coalition for the Homeless and has many other wonderful accomplishments. She serves on the board of directors also for Foundations to Freedom. And with that, I'll turn it over to you, Dr. Rajni. Thank you for being here with us.
Thank you so much. I'm so grateful to be in beloved community today and have the opportunity to share about Foundations to Freedom. As Rachel shared, I'm actually the president for the National Coalition for the Homeless and a professor also at Stetson University. And I serve on the board of Foundations to Freedom and am a longtime community partner with this organization, and really am excited to be able to uplift the work and share some of the wonderful community collaborations that are taking place. So Foundations to Freedom, just to give you a little bit of background, it was founded by, first of all, an amazing woman, my dear friend, Catherine Russell. And Catherine is a survivor, of many traumas, including addiction, chronic homelessness. In addition, she had this long-term dream to really open up for a long time whole well-being center of care, especially to help folks who are in recovery. And so this was really her dream. A lot of it stems from her own experience. At age 27, Catherine had a really terrible car accident on I-4 in Florida. Her vehicle flipped 9 times. She was ejected out of the car and really airflown to Orlando, to our medical center here, was in a coma for 64 days, had several surgeries, over 3 brain surgeries, spinal fusion, reconstructive foot surgery, broken several bones, and was released from the hospital eventually, but was also given very strong narcotics. And so the narcotics to manage pain really led to addiction for Catherine. And so Catherine ended up really trying to dissipate a lot of pain through the medicine, which then became an addiction and something that she is now in long-term recovery for and fighting for, and also spending her life channeling much of that pain into purpose and love to make sure that others have care, fundamental care in all of the ways. And so, she is a joy to work with. I also had a very bad head-on car accident, many years ago when I was in college, and lived experience and traumas being part of my journey. And again, being unsheltered, having to weather the weather, all of the pains and struggles that come with that. It brought me and Catherine together in a very real way, and we have this beautiful friendship. And so when I was asked to join the board of Foundations to Freedom, I was so honored to be part of this. And it's been amazing to see our continued transformation in the community. And so that's what I'm going to share today. And feel free, if you have questions along the way, feel free to lift them in chat. Or even share aloud if you can. And I'm happy to also answer and provide even additional information as we have just a bit of time today. Next slide. So Foundations to Freedom, we really use a collaborative partnership model. And this collaborative model has continued to really grow and expand very intentionally with care and purpose. So if in this slide here, you see beautiful Catherine, that is the founder, and Catherine founded the organization in 2021. So it's fairly new organization, although what I would say is the roots that led to this organization have been multi-year, many past years of community collaboration in the works to finally get it kind of launched in its full form. Now, there is a lot that happens in terms of making sure that we are reaching community in very sustainable ways, in ways that are culturally diverse, in ways that make sure that we are honoring and making sure that people with lived experience are at decision-making tables, are helping to lead, and leading really from an equity stance is something that we are committed to doing as well. Recently here, you see kind of a flyer and setup. We had an exhibition summit, community summit, which is just a beautiful opportunity we do quite often here in our community, where we bring together many nonprofits, community organizations, folks in public health, folks that are working with housing services, folks in education, all into kind of our community center to be able to share resources and insights with families, individuals, but also to be able to connect with each other so we can continue to grow these partnerships. Next slide. So Foundation to Freedom has a really beautiful mission. And the mission really is to provide individuals, and I'm going to add also families, because we've really started to branch out now, seeking recovery from substance abuse disorders with a safe, structured, and supportive home-like environment that fosters recovery, personal growth, and civic responsibility. So there's a lot here in the mission that we could kind of unpack. But I think the main thing, again, goes back to making sure that we are serving the whole being, thinking about well-being from all of the multidimensional dimensions of us as human beings, and making sure that we are using personalized approaches for each individual and family so that folks really have opportunities to be supported and not just survive, but to really thrive. Right? And to be able to bring really freedom into life. Freedom, and we speak a lot about freedom at Foundations to Freedom, both in terms of individual freedom, but also collective and community freedom. Freedom and access to health, access to housing, which is vital, access to make sure that we all have educational excellence and opportunities to education, and making sure that there are intentional threads through all of this that we are cultivating, sustaining, and also actively growing. Also, I want to point out on this slide some beautiful art. I love visuals, and this is artwork by Rafi Mahaba, who's a social justice activist and artist. Next slide. So here, we have this kind of visual, again, thinking about human beings and all of the different needs that we have, but also the strengths that we all bring. One of the things that I really appreciate about Foundations to Freedom is it really operates from a model of strengths-based ideology as opposed to cultural deficit ideology. So we start by recognizing everybody's inherent dignity and beauty and talents and strengths. And then we start to look at, what are the challenges? What are the gaps? What are the areas of support that are needed to ensure that this individual has opportunities, again, to really thrive, really start to manifest freedom, if you will, in their own life journey. And so it's really taking the time to also understand people's diverse stories. Relationships are very central here. And so one thing that you will see is any Foundations to Freedom, any of our homes that we have and our main centers, you're going to immediately, I think, feel that kind of inclusion and warmth when you walk in, because we really try to center human relationships and humanity, and to honor each other's stories and to learn from each other. All of us, right, being able to teach each other along this journey. And so again, there's a very holistic approach that is applied, which offers so many beautiful benefits. And we've been able to see the rewards of this in very tangible ways. Next slide. So here are some other additional kinds of sneak peeks into the world of Foundations to Freedom, right? So Foundations to Freedom, we offer safe, structured, supportive living environments. We have wraparound and whole person care. We have transitional housing, always with the goal of helping individuals move into permanent housing. That is always the goal, right? Making sure folks have permanent housing. And even when individuals move into permanent housing, making sure that supports that are needed are still available and there, and those vital bridges have been built, which we find is essential, especially if we're going to address kind of and prevent, right, re-entry into homelessness, and making sure that people have, again, all of these supports that kind of extend, right, in very, very personalized ways. public health care, having support groups, lots of peer support. So peer support is a central piece of Foundations to Freedom. Therapy and counseling, and making sure that kind of multi-dimensional, multi-pathway counseling and therapy is available, knowing that different therapy and different forms of counseling may work differently for different individuals, and even making sure that we have culturally relevant and appropriate resources available, right, for folks, knowing that, being diverse and making sure that we have inclusivity and inclusion in all of our options is so essential. Education and life skills, making sure that we have long-term success, to maintain sobriety, and then housing stability. This is a big focus. Again, making sure we are helping individuals move into housing stability, permanent housing being so essential to all of the other dimensions of well-being and human rights. In the pictures that you see, you will see some of the different homes that we have been able to kind of purchase, restore. It's been wonderful because we've been able to even take older homes in our community and actually do some restoration, repurposing to bring them back to life, and really make sure that the insides are beautiful, that they are, healing in its nature. So you can kind of see in one of them there, the big wooden tables that we have, really working in local community in every way to make sure that we have local carpenters and folks who are in the granite world bringing in our kitchen supplies. And so it's really kind of community centric at its very heart. But again, the idea is to build something healing and beautiful. So as people are in recovery, there is multidimensional healing even in the environment. And the places are conducive for all of the wraparound care that comes into the homes, right, as we are working to support each other in many ways. Next slide. So whole person care is really central. We are person-centered, making sure we're accessible, that is huge. Physical health, making sure that social emotional health, mental behavior health, financial health, we have intentional curriculum that is built, spiritual health, again, educational opportunities, helping folks, advance their education, whether that's through vocational training skills, making sure that folks have GEDs, folks who are interested in college, making sure that we bridge with college opportunities, career development, and then sustainability supports. And then again, if you look at these 8 dimensions of well-being, there can be many, many more dimensions of well-being, of course, but these are some of the central ones. And what we find in working with individuals is for different individuals, some of those dimensions of well-being might be weighed a lot more than others in their life. And so we really try to listen and honor that instead of kind of a cookie cutter, one kind of response to everybody, right? Making sure, again, that the human story and humans' desires, beliefs, values, dreams are really lifted as well in the process. Next slide. So here, you can start to see here innovative partnerships and multi-dimensional collaborations. And that is really what Foundations to Freedom aims to do. So initially, we were started here located in DeLand, Florida, which is in Central Florida. Since then, again, Foundations to Freedom is continuing to expand, and we're now growing out into different communities and counties. It is a certified sober living residence, offers, again, convenient location, affordable pricing, making sure that, again, we are supporting individuals where they are at and helping in every sort of way to make sure the supports needed are there, in very real and, again, customized ways that really support the well-being of someone. A positive community environment, structured inpatient living to ensure success of long-term recovery. And so again, really focusing on supportive culture. So culture is a big part really making sure, and when we talk about culture, it's not just Foundations to Freedom staff, but making sure that all of the different partners we're working with, we are having very, real dialogue, ongoing reflection, ongoing communication to make sure that we are building and cultivating inclusive culture. And that is an ongoing task and ongoing work, of course, for all of us in this work, as we know. And it takes a lot of investment, but we find that to be really important. That a lot of times, because of high case numbers, which really, again, behind every number is a human life, right? And so we find often, with the overwhelm, things can start to become transactional. And so we try very hard to push against that and make sure things are transformational, that again, humanity is centered in the work. Cost effectiveness, and again, peer support. And the peer support is something that I love. And one of the things that I think Foundations to Freedom is really, really proud of is when you look at the program directors, the folks in several leadership roles across the board, they are individuals who actually came and went through Foundation to Freedom's program. And now they are working and helping others, right? So lived experience being honored, again, being able to lift equity, we're able to then pay people, right? Make sure that we are supporting and investing and helping people along the way. And that is such a beautiful part, I think, of the model that has been developed here. Some of the partners we work with, and we do work with several partners in the community, and we have local, and then we also have national partners, as you may recognize when you start to look. So first, we do work with Rising Against All Odds, which is a nonprofit here in Volusia County. And, we call it RAOO, and they actually provide free HIV prevention, education, testing. They do all kinds of healthcare screenings, help with healthy housing initiatives. There are free they do free notarizations for things and help with IDs. I mean, it is all around, right? And then community referrals as well. Also really working again with SMA Health. And so there's a lot of different services provided here that, are very, very helpful. And again, we try to really partner in ways that are very real and that are helpful for all of the individuals and families that we are working with. And so here with SMA Healthcare, we have various supports and services around crises, residential supports, outpatient centers, and making sure that, again, we're working with all different levels of income, including people who are unsheltered and unhoused, which is really our big focus. Justice services. Another piece of the work that I think is really uplifting with Foundations to Freedom is we've been able to reunify so many families, bring many single mothers and children back together, families that have been divided through various processes, and bring them back together. And that is some of the best work I feel like Foundations does. And then specialty, other services, and lots of community outreach and education. And then again, working with Care Connect really allows different individual needs to be met in different ways, including helping with childcare, making sure that there's childcare of all sorts around different work schedules. Again, making sure that we're helping with those costs. Home and community assistance, visual supports, just a variety of pieces that are important. Foundations to Freedom also partners with Volusia Recovery Alliance. And Volusia Recovery Alliance is dedicated really to empowering not just individuals, but individuals and then also families in journey from recovery to substance, from substance challenges into really making sure that healing is being centered. And so lots of different supports, Narcan kits being dispensed, individuals being trained in overdose response and reversal training, community reported overdose, reversals are really, really huge. And also making sure that all of the individuals are receiving, right, not only supports in terms of healing, but also the educational pieces to help to also heal others. And often as we're doing the work of healing, we're also healing ourselves, right? So again, that honoring of lived experience, but in a very dynamic and multifaceted way. And then Unite Us, many might be familiar with Unite Us. If you're not, it really allows for this kind of robust technology of expansive network, networking around whole person care. So really making sure that, all of the different solutions of social care are really integrated very intentionally, which allows, even as folks are moving through different systems or receiving different services, there is this kind of alignment. And one of the things that we're working very hard to do in our community as a whole, and Foundations is an example of this, is again, being very cognizant of how we can make sure that we reduce trauma, right? And prevent trauma and even heal trauma. And making sure that we are doing that through all of the coordination and services being provided. And then finally, I want to leave a little time for questions, but I just want to share that I'm going to put a link in the chat. And one of the things that we've been doing at Foundations to Freedom, which has been really great, is collecting stories of individuals who've gone through Foundations. And so you can go ahead and watch the stories and kind of hear from people themselves whose lives have been impacted. And many are now working at Foundations to Freedom, which is awesome. Next slide. And these slides will go out so you can kind of look at them to get more ideas of in depth of how Foundations to Freedom works. Next slide. And again, showing kind of the spectrum, right? And the chapter of liberation and self-discovery, and really focusing on recovery, personal growth, and again, moving individuals and families into housing stability. And we work with a lot of domestic violence survivors, intimate partner violence survivors, trafficking survivors. So really have a very diverse group. And again, reuniting families and mothers has been just such a joy. One of the best parts of this work. Next slide. Again, the wellness wheel, again, kind of guiding our work. Next slide. So this is William Doran. He couldn't join us today because he's out in work, had an emergency call, and the people who work at Foundations to Freedom are amazing. And William, in fact, if you go to the link I share later, you can watch William tell his story. William was arrested numerous times, in jail, had many felonies because of substance abuse, was without housing and unsheltered for a long, long time, went through Foundations of Freedom twice because they came through the program, relapsed, and came back into the program, finished with full recovery, and have been in long-term recovery since, but works now as the program director, working with many, many individuals, and is so amazing. And so William's story is one that I think we can all learn from, right? And it tells a lot about Foundation's work. Next slide. And this is just Foundations to Freedom information. So if you want to check out more, we have a ton of information on the website. And if we can share any resources, we are all about sharing. Sharing is caring. So just don't hesitate to reach out. And I want to thank Rachel and Jen and Alicia and everybody for organizing this space and for bringing us together. What a wonderful community. Thank you. Namaste.
Thank you so much, Dr. Rajni. Every time I've got to, if we can go back to the last slide for a second. Every time I get to work with Dr. Rajni, I learn so much more. And just when I think, how much more could this woman be doing in a 24/7, 365-day a week? She proves that she can do more. And in this role as being on the board of directors for Foundation to Freedom, it still just boggles the mind. Thank you for all of your work, and thank you for your work leading the National Coalition for the Homeless through some really rough waters this month and into the future. Thank you. Our next presenter is James Ginsberg, somebody, you can go to the next slide, who I have had the privilege of knowing now, oh my gosh, I think since 2003, so a long time, 21 years. He is the founder and executive director of Recovery Works, a Colorado nonprofit organization serving unhoused persons in Jefferson County, Colorado. He's the former deputy director of Housing Stability and Homeless Resolution for the city of Denver, where he oversaw the city's response to sheltered and unsheltered homelessness and housing instability during the COVID-19 pandemic. James has been working with unhoused people for over 25 years, including 18 years with the Colorado Coalition for the Homeless, where he oversaw multiple housing, case management, and recovery programs. He's the founder and former director of the Fort Lyons Supportive Residential Community, which is the largest recovery program for persons experiencing homelessness in Colorado. And he's also a certified addiction counselor and holds a master's degree in nonprofit management. And thank you so much for being here, James. Really grateful for all of your wisdom and sharing with our attendees today your experience of bringing together all these different systems in a unified manner.
Thanks, Rachel, and thanks, Dr. Rajni. That was very enlightening. I really loved the whole person care emphasis and the peer-directed emphasis, and it's just really a pleasure to be here. Rachel sort of went over my bio. Working with our unhoused neighbors for, kind of pushing 30 years now. And I'm just grateful to all of you who are working with both unsheltered and rural homelessness, two areas close to my heart. And I want to talk about a couple of projects in the context of building partnerships. One is around unsheltered homelessness, the current project we're working on, and then the rural homelessness, Fort Lyon. So please get my picture off the screen. The power of partnerships. I had worked with a large nonprofit, the Coalition for the Homeless, for about 18 years. And certainly sometimes they had a great reputation for being a coalition, and sometimes they had a bit of a notorious reputation for sort of, dominating the space. And I learned a lot of great lessons. Everything I learned about homelessness, I learned there. And one of it was about how to create partnerships and maybe how to avoid ruining partnerships. Next slide. So currently, I'm the executive director of Recovery Works, and we're a fairly small nonprofit in Jefferson County, which is just west of Denver. It's just a Denver suburb. And I had originally, I live in the county. I've lived here for about 20 years. And it was clear that there wasn't a lot going on in terms of a homelessness response in the county. For example, there's not one year-round shelter bed in the entire county. And I was sort of dabbling around. I was working for the city of Denver and was wanting to try to bring some leadership around the issue into this county. And it turns out a longer standing nonprofit had surfaced, and they had a building, this 3,000 square foot building with 11 rooms. And I thought, wow, that would be a great place to do recovery housing. That's really near and dear to my heart. I've worked a lot in the recovery space. I'm in recovery myself. There's a lot of good evidence about recovery housing. And I started to pursue that, my little dream. And it became pretty clear that that's not what the need was in the community. There was certainly that need, but that wasn't the greatest need. And as I started trying to connect with some of the leadership and the nonprofits and the city leaders in the community, and they had been working on a strategic plan, and they were focused on medical respite care as a higher need and emergency services. So I really pivoted away from my little dream and started pursuing this medical respite program. I had some experience with that indirectly with the Coalition for the Homeless. My first call, as I started thinking, who do I need to partner with, was the National Healthcare for the Homeless Council, and they have 8 standards of practice for medical respite care. I started reaching out to hospitals to see what their needs and desire to enter into partnerships was. And it became pretty clear pretty quickly that that I had a lot of folks that were interested in that vision, saw the need for it. And so we turned this recovery community into a medical respite program. So that's we had this house, and it was a great starting point. And on the second floor, there's 11 rooms. So it was a nice sort of community space, but also a non-congregate space in the sense that you had your own room. And then on the first floor, we also decided there was really no drop-in centers. And so we opened kind of an emergency drop-in day center to offer showers and laundry and, kind of the old navigation or day center model. And the day we opened, we outgrew it. So we were clearly meeting an important need in the community. And we were necessarily non-clinical, and so we had to expand our partnerships, especially first of all for the medical respite. So reached out to the local federally qualified health center called Stride, and they certainly caught the vision and were more than happy to provide the medical care. We reached out to the community mental health center, Jefferson Center for Mental Health. They certainly saw the need and it met their goals in terms of outreach to our unhoused neighbors. And so they set up a kind of an on-demand virtual kiosk into their mental health center. We had public health coming in and doing vaccinations, the motor vehicle department, and realizing that a lot of these organizations also had a vision and a goal to be more into the community. And so these partnerships sort of grew organically and naturally as we shared this space and this vision, and really admitting to ourselves that we can't be all things to all people, and where do we need to engage with other partners. We ran this out of this little 3,500 square foot building for 2.5 years. It kept growing in the need. We had, as I said, we'd really outgrown it the day we opened. And so we started looking for a larger space, reached out to the state, and were able to tap into some emergency service solutions, grant dollars, ESG dollars, reached out to the county, and we started showing success and expanding partnerships. The local government started understanding that, how can they adapt their funding, including CSBG and CDBG dollars, in order to help us expand. And so we found a new spot last October, so we moved from basically 1,500 square feet to 10,000 square feet and opened up this large navigation center that we occupy now. We still have the medical respite center at that same spot, still have the same partnerships. And then when we moved into the navigation center, we just continue to increase our partnerships. And this is an ongoing, I'm sort of in the middle of it. We're all in the middle of it right now, adding partners. We have folks coming in, and trying to be really, following the sort of 5 pillars of evidence-based care. Person-centered. We really open this building, and we really are trying to avoid designing this program and asking people to fit into it. And if you don't fit into it, we call you non-compliant. Rather, flipping that around and creating a shell of a program. And as guests come in, they really start dictating what the real needs are. So, for example, adding, we hadn't really thought about adding storage. So adding storage lockers so folks could leave their backpacks while they go look for work or whatever they need to do. Certainly adding showers and laundry, which we're in the process of. That's been a real dearth of resources there. This is, again, there's still no shelter in the entire county. And at this point in my career, I certainly did not want to open a 24/7 emergency shelter, but that's really where the need was, and that's what the community is asking for. And so that's where we're pursuing now. And fortunately, there were a lot of American Rescue Plan dollars that came through the state, and the state has designated a lot of those dollars for homeless response. And so we happen to be sort of in the right place at the right time and moving towards this mission of responding to the real needs of the community. And we're able to get funded for acquisition of the other 10,000 square feet of this building. And we'll be building out a state-of-the-art transitional housing 24/7 shelter. And so then, besides person-centered, strength-based. So really trying, the pathologies of the folks we're working with have been well documented, but the strengths haven't. And they're certainly buried in their long histories of unsheltered homelessness and trauma. And so for our, as we enter into partnerships, we're really trying to educate our partners, whether it's the mental health center coming in or the primary care providers or public health, or even a person coming in to do haircuts or do qigong or 12-step meetings. Engaging those partners in this vision of strength-based, that we're looking at the strengths of the guests we serve, and that's what we're trying to tap into. And one way to do that is to continue to provide more and more offerings so that people can be attracted to, whether it's art or movement or yoga, or certainly everything is case management centric, and everything we do is moving towards that goal of long-term permanent housing. And then, peer directed. So we have a lot of our staff have lived experience, and then we have, peer professionals incorporated in our comprehensive staffing model. And then, recovery based. That recovery is really in the general sense. It's certainly from addiction, but it's also recovery from trauma and from poverty and from homelessness. And so really everything being intentional about recovery. And in our partnerships, understanding that we all need to create sort of the same vibe and the same atmosphere within this space. And our challenge, and certainly has been to not only find the right partners, but to continue to engage those partners in the same vision and mission that we have. And then we, as part of this movement, and this just continues to be a response to the real needs in the community, which of course the solution to homelessness is homes. So we're always trying to move in that direction. We were able, through these ARPA dollars, to buy a 34-unit motel. And we had some permanent housing vouchers attached to the navigation center as well. These were all state dollars from ARPA, so federal dollars passed through the state. And so folks, we can bring them right from the street into the NAV center and then into the motel to just be prepared, get prepared to move into their permanent housing, not in the sense of getting sober or deal with their mental health issues, but more of gathering their paperwork and finding an apartment. So we don't have to try to put that all together while they're on the street. And ultimately, what we're trying to do within this community is develop a rehousing infrastructure. So next slide. And you know, as I'm an off the chart introvert personally, so it's a real challenge for me. The partnerships are so critical, but it's also I know how, but it's also a challenge for me. It takes a lot of energy for me personally to engage in all the relationships that we have to continue to, or we get to engage in, really, and it truly is a joy. And so it's for me finding folks within our own community that are like finding good connectors, and certainly learning that there's people that are trying to get to yes to try to get it done, and there's people that just aren't so much trying to get to yes. They're more comfortable with the status quo, and so it's important to sometimes move on from those folks that aren't ready, maybe aren't early adopters to new concepts, and really spend the energy on folks that are willing to try to be creative problem solvers. That partnerships, we're collaborating with people versus organizations. And that's been really helpful for me to just, as we're looking at expanding services and bringing in multiple partners, you know, who are the people that are going to get things done in the organization, and really work on those relationships. And why do we exist in the community? I think it's a challenge to develop partnerships if I'm just sort of trying to build my own kingdom. I think if we continue to pursue this recovery housing, I'm sure it would have worked and it would have been fine, but it wasn't really meeting the needs in the community. And so to be really clear about where our space is in the community and how do we collaborate. There's other partners that are nearby, faith-based organizations that are doing great work and similar work, and how do we not step on their toes and become an asset and not a competitor in the space. And just coming from the attitude in general of how can we be of service in the community. Next. You know, that's where, you know, I think it's a fine line between, I talked about the organization, you know, that I was a part of for so long, just unbelievable work. And whenever there was a need, you know, they started as doing street medicine, and then, you know, realized they needed mental health care. So they started their own mental health care clinic, realized they needed addiction care and started their own. And so that was great. They kept building out whole person care within the organization. And I think there's a place for that, but understanding where do we want to build it out within the organization, and where do we really want to partner with existing organizations and infrastructures. And sometimes that's more art than science, but I think for me, the first thought is who's already doing what we need to have it done, whether it's mental health care, addiction care, or whatever, employment. You know, we want to expand our employment services. We certainly want to get into more robust addiction treatment around, you know, tapping into opioid settlement dollars. And we certainly have an opioid explosion in this community, as virtually every community across the country. And so we're struggling now with, do we want to build out our own, you know, MAP program, for example, and maybe recovery housing, or do we want to partner with some existing organizations? And again, holding this attitude of being a servant leader, that we're here in the community, not to build our own kingdom, but to be of service to the greater community. and that this is sort of just another version of that, is that, how can we're about building something greater than ourselves. Um, this isn't about our own personal legacies or organizations or grabbing all the resources. This is about making a better overall community, and where do we fit into that? And that, I have found, has been a great framework for partnership, for developing partnerships, and a great foundation for partners sort of coming along and them wanting to bring their service as well. Next. I just talked about that people want to, I think people want to be part of something bigger than themselves, and our mission, a clear vision, is inspiring, and we've been articulating this vision of a rehousing infrastructure and what that might look like, and it's really brought on a lot of partnerships, including city council, city leaders, city managers, folks that are real decision makers and hold the purse strings. And the vision coincided with their current strategic planning, so that really helped to increase the partnerships with the local leaders. Next. And then just briefly, that was the Unsheltered Homeless. We did a rural homelessness project we started 10 years ago. It was called Fort Lyon. It's in rural Colorado, very small community. Los Animas, 2,700 folks. And this was, this is where there's not a lot of partnerships like in an urban environment. So we started reaching out to local community college partners that we wouldn't have thought of before, businesses that maybe we hadn't partnered with before, certainly housing authorities, but we really focused on this Bill Long County Commissioner. And over the course of 18 months, he was the one that was a real decision maker within this community, and spent nearly a year and a half developing just a relationship with him so that he could know who we were. These city slickers sort of coming into a rural community and bringing homelessness into their community, that was sort of the narrative. And as we developed this relationship and he became comfortable with what we were doing, we were able to create this incredible 250-bed recovery community that has served over 3,000 people and is still going strong. Next. I talked about Recovery Works and what we're doing, the politics and the population. So let's go to the next one. These are just some of the partners that we're working with now. City and county and state, public health, community mental health, so criminal justice system. We have probation comes in, we do a so-called homeless court here, trying to bring every service into this one space to treat the whole person. It not only helps the guests that we're serving and our unhoused neighbors, but it also helps the mission of all our partners who want to reach this community and don't really know how to. Next. All right. And that's it for me.
Thank you so much, James. Really appreciate just the many years of expertise, wisdom, partnership. I really appreciated, your sort of frame of let's be about something greater than ourselves together. And that's really what this whole learning community is about, all 4 sessions, right? How can we partner with other systems to create something bigger and better than just what we offer ourselves? And for those of you who are joining today who are newer to this field, maybe you've been doing this work for 4 months, maybe you've been doing it for 4 years. Just know that that Dr. Rajni, that James, our next speaker, Daryl, have been doing this for decades. And we just want to give you hope, and give you some wisdom about all the ways in which you can create something bigger than just yourselves, your organization, in partnership with lots of systems. So I would like to introduce Daryl. I believe, Daryl, that Mike is not going to be joining us today, but Daryl Mitchell, over the last several years, has led and impacted change in the recovery supports field at the state and national levels. He's the founder of the Indiana Affiliation of Recovery Residences and serves as the president of the National Alliance of Recovery Residences. In 2017, Daryl was instrumental in the drafting and passing of legislation that placed recovery housing standards into Indiana law. He has a Bachelor of Science degree in addiction counseling and a master's in business administration. And while he didn't plan a career in health and behavioral health care, he is grateful that with the help of others, he overcame addiction and has been a person in long-term recovery for many years, which has led for him to be able to pursue a new professional path of service to those with mental illness and substance use disorders. In 2019, the White House Office of National Drug Control Policy and the U.S. Department of Agriculture asked Daryl to author a paper for the Rural Community Action Guide. And this guide has been distributed nationally to equip rural leaders with critical information from lessons learned from the front lines of prevention, treatment, and recovery in rural America. And so we're very appreciative that Daryl is joining us today. And Daryl, we'll turn it over to you. Thank you.
Thank you very much, Rachel. I just have to be honest, it's painful to sit through that bio. And I want to share that Mike, my colleague, is in Hawaii. So if you want to just put a whole bunch of stuff in the chat harassing Mike, I would take screenshots and make sure that he sees them. So why don't we go to the next slide? It's going to talk about Progress House and Progress House joining a larger healthcare agency and system, Aspire Indiana Health, and how we've established this whole health recovery continuum in a residential setting and working also in our outpatient setting as well. If you take a look at the next slide, I'll tell you a little bit about the story and why it was important to seek out this partnership. Progress House was founded in 1961, so it's the oldest and largest recovery residence in Indiana. We are shortly going to, we're doing some expansion and renovation at our site. We'll be serving 104 in that building that you're looking at, 104 men. So we'll be 63 years old this December. And for many decades, it was considered one of the premier recovery houses in the state. But as many of you may be aware, the opioid epidemic has basically shifted the average profile of the people that we're serving in these types of facilities. So, you know, that first wave of the opioid epidemics were really about prescription opioids that led to fatalities. The second wave was around heroin, you know, when there was a tightening down of prescriptions that were being written, you know, across the country. You know, people were looking at ways to avoid dope sickness and those types of situations. And so heroin became a more popular drug that people across all kinds of different lines began accessing, and that led to a bunch of fatalities. And now what we've seen is this resurgence of things like fentanyl and new introduction of drugs like xylazine that are causing you know, fatalities. So what's happened is recovery housing, I think for many years, the typical resident that was served in this type of facility was a middle-aged alcoholic. And these substances, the opioids certainly, but then some of the, you know, the synthetic drugs that have been produced, we see people getting in trouble at a younger age, hitting a bottom sooner than, you know, previous decades. And, you know, one of the things that I found is that we were still doing the things we had done for many, many years, but we weren't being as successful. So we needed to reimagine how we were delivering services. And so I began looking for a partner, across the community, and we've had a variety of different partnerships. But I was looking for something that could provide what I was imagining as whole health. We've heard, the other speakers talk about whole health. So in 2019, after about 10 months of due diligence and the board's convening, we became a wholly governed subsidiary of Aspire Indiana Health. And I'll tell you a little bit about them and then how this has impacted our outcomes. So if you want to go to the next slide. Who Aspire is a fully integrated healthcare provider. So they provide medical care for physical health. They're a federally qualified health center, so that's funded through HRSA. They're also a community mental health center, CMHC, so they have behavioral health services. Also provide social services, social drivers of health, and provided services to the substance use disorder population. So collectively, the organization's had about 115 years of serving this complex group. These are nonprofit independent organizations. So when organizations merge in the nonprofit world, you don't buy and sell nonprofits, through board governance. What happens is you have an opportunity to be governed by another organization. And one of the things that I found in some of the partnerships that we established before becoming a part of this larger healthcare system, it was difficulty, getting warm handoffs at times, but also having communication necessary among the different providers to make sure that that individual is receiving the best care. So if we take a look at the next slide, what I saw in the Aspire organization was an organization that had provided or actually had consolidated their medical services, their healthcare services, as well as their behavioral healthcare services. And that is not typical for an organization. And what led that initially was they were treating the seriously mental ill population, and they found that that group was dying 20 to 25 years before their counterparts, but they were dying from healthcare related reasons. So it was things like diabetes, lung disease, heart disease, other health issues. So they had combined the primary care and the behavioral health systems, which is somewhat culturally. And so as I met those folks and realized that we were treating some of the same clients, I also saw what I thought was going to be one of the biggest hurdles, which was the cultural hurdle. And I thought that there was an openness to have recovery support services and people with lived experience at the table. So that as you're staffing an individual and you're talking about the ways in which they need to be served in all of these areas so that they can get, really truly achieve whole health, would there be, is there a culture, would there be a willingness for a physician and a nurse or a medical assistant to sit down with a case manager and a recovery coach and a peer specialist and or people that were in our operations team that were really just organic from the ashes recovery people, but were wanting to work in this space to be of service to those folks like themselves and talk without ego, without any other things that would cause obstacles. And so we identified, well, what are all the areas that we have to serve? This was before the Office of Recovery was open up at SAMHSA, but I love the way that they look at the domains, and describe recovery and the need of all these various things to be provided to somebody in order for them to be able to achieve long-term health, in this case, long-term recovery. So these are the four major service lines that we've established and braided together so that we have these behavioral health care services in the upper right, which is basically outpatient, a lot of home and community-based services. We have supported group living and for the SMI population. And then we also have a medical and legal aid service for the people that we serve. On the primary healthcare, we're your family doctor. So infectious disease. We also do some behavioral health out of the health clinics, for that short-term 30 and 60-day care. The recovery communities, I'll talk to you a little bit about those. Mockingbird Hill is our treatment facility with 88 beds, Progress House 104, and then we have Next Step or transitional housing where people can step down from that 6-month program at Progress House into 2-year, 3-year, longer transitional housing, still in a recovery environment. And then all these social drivers of health. We do have HUD programs and rental properties, permanent supportive housing, emergency housing solutions, but also provide employment services, across the spectrum of people that we serve. So if we take a look at the next slide, what that shows us. So the next slide, please. Is these are the various pieces that we've put together in this continuum, which I'll show you next, which, somebody may have an acute, say that somebody actually has an overdose episode, and they're often sent to a psych ward or to an emergency room. Well, that's a very short stay. But we knew that we needed to be able to then get them into a treatment facility to be stabilized physically and mentally. So Mockingbird Hill is the first stop for them. And all of these components are available at Mockingbird Hill, with the exception of recovery housing. And I'm going to swap that when I get to the Progress House description. So they're going to receive primary medical care, withdrawal management, and assistance with medication-assisted treatment. So the physicians will actually prescribe and do the induction on the MAT medication. And then the withdrawal management piece, they'll begin with the individual therapy, but they'll go through an assessment with the psychiatrists, the medical staff, our addictionologists, and ensure that they're getting on the appropriate mental health meds as well, to put them in a position of not only getting stable, but for future success. Individual and group therapy, I mentioned peer recovery and our recovery coaches. The recovery house is a 12-step model. And then we provide housing assistance, helping people to get to that next phase, employment and education, case management. So those things are all at Mockingbird Hill. When they step into Progress House for that 6 months, they then are in this recovery housing scenario. So that does apply. And now, they're not going through withdrawal management, since at this point they would have been abstinent for at least 28 days generally. But they are continuing their medication-assisted treatment, and then they can move on to next steps. So right now we have just under 250 beds, and we're adding about another 32 beds in the next handful of months, and then actually hope to add another 100 beds, next year, because there's these comprehensive services. What we found is we're located in the middle of Indiana. It's a state with 92 counties, but we're getting people referred from 62 counties because of the comprehensive services. So the next slide just kind of shows somebody's journey in a residential setting, in that yellow arrow that I just kind of described. In acute care, moving into treatment, moving to the recovery housing, and then moving into longer term transitional housing. Now, the nice thing about this relationship and being part of this larger network now is that when somebody is ready to step out of these facilities and go back into whatever community they've come from, and be either rejoined with family or go back to where they were before, so they can work or whatever their plans are. Those purple arrows all are pointing to the 6 outpatient clinics that we have that provide medical care and behavioral health. So they can, they're now a patient of the system. If they need to get assistance with their mental health, they can go and see somebody in an outpatient environment. But through that yellow arrow journey that they've traveled, they also now have a community that they've gotten sober, they've entered and progressed in their recovery with. So that community and the sense of purpose and having the support is so critical, in somebody's recovery journey. I know, if someone were to ask me how I would describe recovery, but not use the word recovery, I'd say connection or community. So that is critical, that they have those things as they step back into this other environment. What's happened as a result of this, our next slide, is we've gone from success rates that were running 28 to 30% was kind of the norm, for decades, when we were just offering the safe, sober environment and really offering informal recovery support services before recovery coaching and peer specialists were actually certifications that were available. But as a result of using these integrated services in a way that's seamless for the client, so that the client doesn't care where the funding's coming from. They just know that they're not savvy healthcare navigators. And here they can just go up the hallway or upstairs to receive whatever the service is in the facility where they also live and they eat and they're going to other programming. As a result of that, we've seen, our success rates double. So we've gone to 60% plus of those that begin the program completing it. So that 6-month program is what I'm describing. More, I think, telling if you're able to witness this, and I feel fortunate to be able to see these miracles occur, is I'm seeing the changes in behaviors and mannerisms, the language, people being inspired to want to give back to their communities, wanting to be a mentor, wanting to enter this space professionally. And so over that period of time from 2019 to 2023, there were 1,238 men served in that core program, but more than that through the entire continuum. So moving on to to Mike's slide. So Mike oversees the social drivers of health portion of our services, where actually employment assistance, housing through some of the HUD programs, housing first, things like that. Some legal assistance with people, primarily not with criminal convictions, but civil problems, education and certification, benefits counseling, and then ensuring that people have access and resources to food and clothing. We serve 37,000 unduplicated clients in this whole system. So being able to offer these things outside of the residential clinic is really critical. One of the things that Mike mentions in his next slide, was just the need to not weaponize the word integration and to not just say that you're offering integrated care. We actually probably would prefer to use the word inclusive care now, so that this is a place where, that we just don't have silo departments offering particular services, but that these, departments are actually coming together to ensure that the clients that we serve have inclusive care where these integrated services are delivered so that there can be an opportunity for whole health. The next slide are just a few of the examples. We have multiple EHRs because you had a healthcare system, a behavioral health system, and these other social services, residential. We're going through the process of having one EHR and allowing, our operational people to do referrals through the EHR, doing acknowledgement of referrals, entering notes into the EHR. So it's not just licensed professionals that are able to enter into the record. And there's PHI issues that are managed, but you can see somebody's journey as they enter the organization and they travel through and then beyond. So this is about moving past integration to unified or inclusion. That is all I have. I wasn't sure how I was doing on time. Rachel, I wasn't watching the clock, but hopefully we're okay.
You did just great. Thank you so much, Daryl. Really appreciate you and all that you all are doing. I didn't recall you served 37,000 unique individuals. That's incredible. I think Teresa's gonna facilitate some questions, and we welcome you all to put any questions into the chat. Teresa, we'll just let you kind of pick and choose which questions to go with here while we have about 15 more minutes. We do want to just remind folks at the end of this, we do have an evaluation that we hope that you'll fill out. It's really helpful for myself and for Teresa in shaping these sessions and future sessions to have your all's feedback. Thanks.
Thank you so much, Rachel. And just again, thank you to our presenters for sharing your wealth of information and also really encouraging this group to think about the whole person. I always say, and I think I've said already in a session in this cohort, is it's so important to think about what's possible and have those living examples of what's possible to do in someone's community. So I'm just appreciating what you've shown us all today. So I think I'm going to start with the questions that could be given to anyone instead of doing the individual questions. If we have time, we'll get to those. And I will be monitoring the chat. So again, these ones, anyone can jump in of our presenters to answer. And so the first one I'm going to start with is, how do you incorporate culturally responsive practices throughout your programs?
I can comment on that quickly. I made a reference to it. That's hard work. That is more difficult than just saying, here are the boxes that we can check if we can deliver the following services. If you truly want to be able to bring, partnerships at a different level, which I think ultimately provides better care, then there has to be an opportunity for people to be able to sit down in an environment where title is not as important as the client. And that's generally something that you wouldn't see, for example, in a hospital environment. That's a challenge, to say, okay, we're going to have this surgeon or this specialist sitting down with a tech person, right? So what we're describing are people with lived experience, people with certifications, and people with licenses, all being able to talk about the client and the welfare of the client. That requires cultural work among the people that are having those conversations before you begin to execute those services. So all I can say is that for me, when I begin looking for partners, I asked questions that I think drove the type of conversation that allow me to have some intuitive thought around, is this going to be a good partnership for us or not? Or is this just unable to change from the way that they've traditionally done things? Because what we really have is a healthcare system that treats the sick. We don't have a system that deals with wellness. And so what we're talking about here is a little bit different. And, in all three of our cases, it's about wellness and sustainable recovery. So there's no silver bullet answer, but I would say that's one of the more challenging things, and yet probably the most important thing to just be aware of.
Thank you. I appreciate you sharing that. And I think James talked about that a little bit also in assessing who your partnerships might be. Dr. Rajani, I saw your hand up. I don't know if you want to speak to that as well.
Sure. Yeah, no, I was going to say, some of the I think intentional work we do to make sure that we are staying culturally responsive is making sure, first of all, that internally diversity is represented, right? So and that's not always easy to do, but making sure that when we think about, recruiting, we have diverse representation. And it's not just with recruiting, but also retaining. And that goes back into culture building. So making sure that we are working constantly on ongoing reflection with inclusivity, having channels for open dialogue and pathways to give feedback and for sharing and listening to people's stories. Really working from a place of cultural humility instead of kind of cultural competence. So making sure we understand that culture is dynamic. Everybody has their own cultural pieces and dimensions that they bring into a space. And so making space to listen and to learn and not make assumptions, I think, is part of it. And then even doing a lot of, ongoing professional development, if you will, but in really meaningful ways. So it's not just kind of one time a year, but, a lot of times I end up coming in and I'll do workshops, for our staff members, and we have dialogue, and we're doing it all the time because folks then end up bringing in real examples that we can work through. We can start to apply, bringing in different tools for our toolkits, if you will, in a sense, that can be really helpful as we're navigating different situations. And then also taking the time to constantly learn, right? Learn and also assess our own kind of organizational culture. And are we, again, centering, leading with inclusivity and honoring diversity and equity in the work that we're doing?
Thank you so much for sharing that. And I particularly appreciate kind of that ongoing learning, because I think something that we see and we're really encouraging people in this cohort to assess for themselves is, are we using training as a checkbox, or are we using it as a meaningful tool to develop and serve people better? So thank you for lifting that up. So you mentioned representation. I think another thing we've been talking a lot about in this cohort is how we're making sure that we're integrating roles with people with lived experience and the voices of lived experience. Can you share more about the impact of integrating people with lived expertise in your service delivery models, whether that be in professionalized roles or just making sure you're integrating the voices of folks that receive your services or potentially would receive your services?
Sure, I'm happy to comment. Again, we've actually designed a pathway for those men that come through our program who are interested in working at the facility, some entry-level positions, and our entire operations team is made up of former residents, program participants. And I think that's, we've seen the impact of peers, in emergency rooms and at various different facilities. And we understand how important it is, and how people will respond to somebody who has been through something they've been through. So I think it's one of the secret ingredients to the secret sauce, if you will, because when somebody will come into a facility and they're new, they're intimidating. And oftentimes, people with substance use disorder problems, and I think in general, we think we're terminally unique and nobody's going to understand, what I've been through or, the guilt or shame that I have or what I have to overcome. And so it's very powerful to say, I want you to meet some men who work here and they've all lived here. They've all come through the program. They've all walked in and, for that first time, being overwhelmed and intimidated. But I want them to share with you what it was like before they got here, what they've done, and what things are like for them now. So that's just in a real practical sense. And we serve thousands of people. So not everybody, I have 10 guys on staff that do that, the 30 people at that facility. So not everybody is bitten by that bug to want to, but when you find somebody that really wants to be in this space because they cannot not be in this space because what happened to them, you really end up with an amazing asset and an employee.
Thank you. Thank you so much for sharing that. Dr. Rajni, I think I saw your hand go up again.
Yeah, sure. No, I just was going to share, the value of integrating people with lived experience and expertise. It is just so profound and honestly really imperative to all of the work. So what we see is when, people who are most impacted, in our communities in a number of ways are part of decision-making, solution-making, all the way from, ideation to implementation of things. There are benefits that happen all around to everybody who's involved. And so, making sure voices, people's agency is included becomes super important. And there's lots of, and making sure we're paying too. I just want to say equitably, people with lived experience who are brought into the work. And there are lots of different roles folks can play as well, depending on, maybe their context or situation in life. And so, sometimes it's, having dialogue with individuals to see, what are their strengths? What are their talents? What would they want to offer? And what spaces and roles, would they want to play at this time? Right. And so there's just such benefit in that. And again, even when we think about lived experience, there's the saying that comes out of the disabilities movement, nothing without us, right? For us. And I think that's part of it is because we have seen historically where often, regardless of issues, kind of systemic issues, where people who are being impacted when they're excluded are not, included in ways in all of these processes, there can often be unintentional, it's not always intentional, but even unintentional harm and damage and traumas that are unleashed, that are very real. People who are, even have the biggest of hearts and think they're helping, but in fact can be causing a lot of trauma and harm. And this is where lived experience can come in, and there's wisdom and, there's opportunities for kind of creative, diverse thinking models. And so just lots of benefits. And I have tons of resources. So if anybody is working to integrate people with lived experience and expertise, feel free to reach out and happy to share.
Thank you, and thank you for offering that. I hope that folks will take Dr. Rajni up on that because I think as both she and Daryl mentioned, I saw Rachel clapping. I also wanted to clap, but being mindful that I'm on a microphone and that probably wouldn't be great for everyone, how critical that is and how we have so much to undo in terms of the history of creating systems for people without listening to people and without really truly understanding what would help them the most and what would feel meaningful to them. So thank you both for answering that question. I think we probably have time for one more quick response. So I think this one is a practical question, and I'm sure so many people in this audience would like to hear about your strategies for this. What sources of funding are you using to cover the cost of supportive services? How are you braiding it? Like, could you speak a little bit to your strategy there, since it is a challenge for so many?
Yeah, sure. So we like to go in the same order again. For years I raised money to operate, and so it was completely philanthropic. And this population we're serving is typically a population that oftentimes walks in with just what they have on their backs. And so finding somebody who was able to offer FQ services and bring those and embed them in our facility, right? So the FQ site is there. That's funded through HRSA. So that's federal funding. The community mental health centers that they're able to bill some Medicaid. In Indiana, you can bill Medicaid rehabilitation option for those therapeutic and clinical services. So that's that piece. And then there's a couple other funding streams in Indiana. One for convicted felons or someone charged with a felony. There's kind of a stopgap program called Recovery Works, similar to James's organization, and there's a certain amount of housing dollars. So, and then SOARS, the State Opioid Response Grant. So we braid those funding streams together in a way that somebody doesn't have to begin working right away, so that they can begin focusing on their recovery, and then they can move into employment at the appropriate time. And then if somebody doesn't qualify for one of those funding streams, then we still do raise money for what we refer to as scholarships. And we'll simply say, whatever you don't have in finances, you can make up for in willingness. And here's what we mean by that. This is about, taking action and being willing to take instruction and be, a good member of the community and all those kind of things. So there's obviously always on the lookout for grants and things like that. So there's different ways that we try to pull all that together.
Thank you so much. And I'm so sad that we don't have more time to get to more of these questions for you to just share more of your experience and wisdom. So if folks do have additional questions, you can submit them through the portal. I know Rachel did drop that link in the chat, and we also dropped the link for the evaluation and certificate of participation, but there's a QR code here, which we'll leave up on the screen for a moment. And aside from that, I just want to thank everyone for being here today, our panelists and our audience for being great listeners. So appreciate all the work that you all collectively are doing, and just a lot of gratitude and thanks. So thank you everyone for joining us.